Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 2 of 2 on the clinical assessment of visual function in this chapter. Eye movements are tested by asking the patient with both eyes open to pursue a small target such as a pen tip into the cardinal fields of gaze. Normal ocular vision is smooth, symmetric, full, and maintained in all directions without nystagmus. Saccades or quick refixation eye movements are assessed by having the patient look back and forth between two stationary targets. The eyes should move rapidly and accurately in a single jump to their target. Ocular alignment can be judged by holding a pen light directly in front of the patient at about 1 meter. If the eyes are straight, the corneal light reflex will be centered in the middle of each pupil. To test eye alignment more precisely, the cover test is useful. The patient is instructed to look at a small fixation target in the distance. One eye is occluded with a paddle or hand, while the other eye is observed. If the viewing eye shifts position to take up fixation on the target, it was misaligned. If it remains motionless, the first eye is uncovered and the test is repeated on the second eye. If neither eye moves, the eyes are aligned orthotropically. If the eyes are orthotropic in primary gaze, but the patient complains of diplopia, the cover test should be performed with the head tilted or turned in whatever direction elicits diplopia. Stereoacuity is determined by presenting targets with retinal disparity separately to each eye by using polarized images. The most popular office tests measure a range of thresholds from 800 to 400 S of arc. Normal stereoacuity is 40 sec of arc. If a patient achieves this level of stereoacuity, one is assured that the eyes are aligned orthotropically and that vision is intact in each eye. Random dot stereograms have no monocular depth cues and provide an excellent screening test for strabismus. The retina contains 3 classes of cones with visual pigments of differing peak spectral sensitivity: red, green, and blue. The red and green cone pigments are encoded on the X chromosome, the blue cone pigment on chromosome 7. Mutations of the blue cone pigment are exceedingly rare. Mutations of the red and green pigments cause congenital X-linked color blindness in 8% of males. Affected individuals are not truly colorblind. Rather, they differ from normal subjects in the way they perceive color and how they combine primary monochromatic lights to match a particular color. They can be classified as anomalous trichromats and dichromats. Acquired defects in color vision frequently result from disease of the macula or optic nerve, cerebral achromatopsia, prosopagnosia, and color anomia. Anomalous trichomats have 3 cone types, but a mutation in 1 cone pigment, usually red or green, causes a shift in peak spectral sensitivity, altering the proportion of primary colors required to achieve a color match. Dichromats have only 2 cone types and therefore will accept a color match based on only 2 primary colors. Both anomalous trichromats and dichromats have 20/20 visual acuity. Ishihara color plates can be used to detect red-green color blindness. The test plates contain a hidden number that is visible only to subjects with color confusion from red-green color blindness. Vision can be impaired by damage to the visual system anywhere from the eyes to the occipital lobes. To better understand visual field problems, let us orient ourselves once again that the visual field of one eye involves both nasal and temporal portions. The temporal branches of the optic nerve do not cross each other, but the nasal fibers cross each other at the optic chiasm. The nasal portion of the eye sees the temporal visual fields, while the temporal portion of the eyes sees the nasal visual fields. These are processed into one image in the visual cortex. The crux of a visual field analysis is to decide whether the lesion is before, at, or behind the optic chiasm. If the scotoma or the visual field defect is confined to one eye, it must be due to a lesion before the optic chiasm. Retinal lesions produce scotomas that correspond optically to their location in the fundus. A superior nasal retinal detachment results in inferior temporal field cut. Damage to the macula causes a central scotoma. Glaucoma selectively destroys axons that enter the superiotemporal or inferotemporal poles of the optic disc, resulting in arcuate scotomas shaped like a Turkish scimitar. Other conditions that produce a similar visual field defect are optic neuritis, ischemic optic neuropathy, optic disc drusen, and branch retinal artery or vein occlusion. Damage to the entire upper or lower pole of the optic disc causes an altitudinal field cut that follows the horizontal meridian. This pattern of visual field loss is typical of ischemic neuropathy, but also results from retinal vascular occlusion, advanced glaucoma, and optic neuritis. Damage to papillomacular fibers causes a cecocentral scotoma that encompasses the blind spot and macula. If the damage is irreversible, pallor eventually appears in the temporal portion of the optic disc. This may be seen in conditions such as optic neuritis, nutritional optic neuropathy, toxic optic neuropathy, Leber's hereditary optic neuropathy, Kier's dominant optic atrophy, and compressive optic neuropathy. At the optic chiasm, fibers from nasal ganglion cells decussate into the contralateral optic tract. Crossed fibers are damaged more by compression than are uncrossed fibers. As a result, mass lesions of the cellar region cause a temporal hemianopia in each eye. Tumors anterior to the optic chiasm, such as meningiomas of the tuberculum sella, produce a junctional scotoma characterized by an optic neuropathy in one eye and a superior temporal field cut in the other eye. More symmetric compression of the optic chiasm by pituitary adenoma, meningioma, craniopharyngioma, glioma, or aneurysm results in bitemporal hemianopia. It is difficult to localize a post-chiasmal lesion accurately because injury anywhere in the optic tract, lateral geniculate body, optic radiations, or visual cortex can produce a homonymous hemianopia, which is a temporal hemifield defect in the contralateral eye and the matching nasal hemifield defect in the ipsilateral eye. Damage to the optic radiations in the temporal lobe or the Meyer's loop produces a superior quadrantic homonymous hemianopia. Injury to the optic radiations in the parietal lobe results in an inferior quadrantic homonymous hemianopia. Lesions of the primary visual cortex give rise to dense, congruous hemianopic field defects. Occlusion of the posterior cerebral artery supplying the occipital lobe is a common cause of total homonymous hemianopia. Some patients with hemianopia after occipital stroke have macular sparing because the macular representation at the tip of the occipital lobe is supplied by collaterals from the middle cerebral artery. This ends the slide set for clinical assessment of visual function. Next set of slides will discuss red or painful eye disorders.